Hello, my name is Joel Dunning. I'm delighted to be here at EACTS with John Puskas. John, so pleased that you're here. You're obviously the Professor of Cardiovascular Surgery at Mount Sinai, and you're Mr. CABG, I always think. And you've started so much on it, co-founder of the International Society for Coronary Artery Surgery, and you've done so much for coronary artery surgery worldwide. And I was really excited to hear about this fantastic session you've just been doing at EACTS, all about a CABG Academy. So tell me a little bit about what you've just been doing this morning at EACTS.
Well, Sigrid Sandner and Mario Gardino designed a really fabulous session this morning, really focusing on some unusual challenges in coronary surgery, not the run-of-the-mill kind of questions, but rather some esoterica, some complex problems that occasionally crop up and can befuddle the coronary surgeon.
Yeah, and your talk specifically on a topic that makes me feel sick, ripping out those stents without destroying the whole vessel. I mean, what are the hints and tips of doing a stentectomy?
Well, as you know, coronary endarterectomy has been around a long time. Coronary stentectomy really is the next generation of endarterectomy, really forced upon us by the proliferation of stenting, especially redo and redo stenting, such that full metal jacket can become a relatively common problem, especially in the LED territory, where perfusion of the anterior wall and the septum is so vital to long-term survival and to quality of life for angina relief. We really have to be able to achieve revascularization of that territory of the heart above all else. So that if the LED is chock-a-block full of stents, now we're left with a problem. Is there a surgical solution to the full metal jacket with in-stent restenosis of the LED? And we are tiptoeing into that field with some trepidation for obvious reasons. But we've had some successful early cases with some 1 and 2 year follow-up now. So we're cautiously optimistic that techniques can evolve and can address this problem for selected patients.
So there's got to be a lot of surgeons out there going, oh my God, I've never tried to rip a stent out. So what's the first one that they should do, and what are those hints and tips to keep them safe?
I'm not sure this is a procedure that should be done widely. It may in fact be a procedure that should be restricted or referred to a coronary reference center. It doesn't make much sense to me to do one of these every other or every 3 years. I think this is something we should refer to surgeons who are particularly interested and focused on coronary surgery. That said, I think the LED is the territory where this kind of endeavor may be worthwhile because it is so vital to myocardial function.
And comparing it to endarterectomy, is this a level up in difficulty? Does the actual stent itself embed itself deeply into the wall? Which ones wouldn't you touch, and which ones do you think this won't be so bad?
It's a great question. We have found that some come out surprisingly easily, much like a nice, easy endarterectomy. Occasionally you'll find a patient where that layer between the adventitia and the media intima core separates surprisingly well. And then we found a few where there seems to be so much fibrosis that plane is just impossible to develop. And we've had to back out and say, no, we're going to end up destroying this vessel. We're not going to do an endarterectomy. We're going to bypass the apical vessel and call it a day. So I do think one has to exercise judgment, not just in patient selection, but during the course of the surgery, in terms of are we going to progress by what technique, and is there a moment where we should say no, we're about to cause more harm than good?
And is there anything on an angio past history of the stenting that makes you either in favor or never again? Is it types of stent or overlapping or multiple layers of them?
Great question. Those that we've done have all been multiple layers. They've all been multiply stented LEDs. I've restricted this to LEDs alone. And they've all been multiple layers. I would say sort of 5 out of 6 we can do. Maybe 10 to 20% we find that it's just a plane we cannot develop. And I don't know whether that is brachytherapy, that is one of the bailout techniques that interventionalists use to try to deal with in-stent restenosis. That, in my experience, has either produced, early after brachytherapy, it seems to produce some edema, which may make that plane easier to develop. But later, it turns to really rigid scar. So without any controlled data, without certainly no randomized kind of a comparison here, but my intuition is telling me that recent brachytherapy may be a green light, but brachytherapy 2 years ago might be a red light. It may indicate that that plane will be more difficult, actually fibrotic and sort of non-existent as a dissectable plane. And after all, this is a matter of anatomic dissection. One must leave the adventitia behind and remove only the media and intimal core in which is contained the stents. Otherwise, the operation becomes a catastrophic endeavor.
Absolutely. My God, I'm already shaking doing that. I think, to me, the message is sent to an expert, but those early results...
And that may not be a bad proposition. I think the message is that we ought not to simply give up on that growing number of patients who have a full metal jacket of the LAD with in-stent restenosis and relentless angina, telling them, triple anticoagulation therapy is all we have to offer you. That may not any longer be true. We ought to at least make a referral of that patient, let us have an assessment, and consider whether surgical therapy can have benefit. Obviously, if it's both a full metal stent and a deeply intramyocardial LAD, I think that's a no-go zone, right? So we do a CTA with 3D reconstruction to ensure that this at least will be an epicardial vessel. I can't imagine a scenario where I would be interested in attempting this in a deeply intramyocardial LAD. That's certainly a bridge too far in my mind at this point in time. So we want to know that it's an epicardial vessel. I think it's rather helpful if there is a ramus intermedius or large diagonal nearby that's independently stenosed and needing a bypass, because provision of that bypass will be a routine part of the operation and should have some benefit and provide some collateral flow in that region as a bit of a safety net. I think it's important to not try to do this operation, removing a full metal jacket, for in-stent restenosis that is mild to moderate. If there's still a lumen in that stent that's 1.5 millimeters wide, then there's a lot of flow. And if that stentectomy goes wrong, you will have had a net decline in flow. But if the full metal jacket is squeaky tight in-stent restenosis or a chronic total occlusion, in some sense you can't make that much worse. And you may be able to make it much better with the endarterectomy stentectomy. So the selection of the patient, I think, is critically important, even before we begin to talk about the nuances of the technique.
And so you dealt with a few other sort of niche things in this academy, which is great. And one thing that came up was, what do we do with coronary aneurysms? So every surgeon sees one or two a year, or maybe every couple of years. So what were the main messages that came out of that session?
Jim Tatulis from Melbourne gave a lovely summary presentation on coronary artery aneurysms, and I think the key take-home message there was that they should be dealt with. They are typically the result of proximal stenosis. So the aneurysm is a peristenotic phenomenon. Occasionally they result from infection or previous stenting or trauma, but the large majority are atherosclerotic in origin. They develop in association with a stenosis. Usually we can simply bypass that stenosis and ignore the aneurysm. On the other hand, larger aneurysms pose a risk of embolism, thrombosis, or even rupture, and they have to be surgically dealt with, which is an on-pump operation. It's an arrested heart operation. Typically, we would oversew the aneurysm from the inside, both proximally and distally, and then bypass that aneurysm more distally with a suitable coronary conduit.
And experience-wise, for somebody who may not have done that much, I guess that's at least more simple than the stentectomy. That's just good selection, and the message is just do it. Yeah, it's do it, and don't be too scared. So that's great. And then another subject that came up was anomalous origins, in which again people see every now and again, don't they?
Every once in a while.
But actually, there is a way to deal with these. So what were the messages that were given out there?
By far the most common anomaly of coronary arteries in adults is anomalous origin of the right coronary from the left coronary sinus of the aorta, with a typically oblique orientation, slit-like orifice, And those patients may or may not present with obvious signs of ischemia. Occasionally they present with arrhythmia or even sudden death. New imaging modalities, CTA, the high resolution CAT scanners can help make images of the ostia and show us that it is truly a slit-like orifice. In my own experience, we've done maybe 30 of these now and have a real interest in that phenomenon. It is always a slit-like orifice that is the problem. We always do an unroofing procedure for that. And then marsupialize the neo-ostium with interrupted 7/0 proline sutures to avoid the possibility of dissection at that zone. We've had really excellent results with that. I think this is actually a niche procedure that probably should be referred. This is not an operation that one should do once or twice in one's career. But it's a procedure that with practice, it can be done expeditiously and reproducibly.
Great. And so right carotid is the most common, and I guess have you done some others with anomalous left?
Occasionally we see the left in adults. They more commonly present in children, of course, so the congenital surgical colleagues take care of those. But occasionally we'll see a left originating from the right ostium, which typically has a longer intramural portion, so typically passing behind the commissure between the right and left cusps of the aortic valve, and may require that the commissure be taken down. The unroofing may need to be longer than in a right anomaly, and then we typically have to tack back up that aortic commissure to avoid valvular insufficiency. But it can be managed the same way with unroofing. I think only occasionally, usually as a bailout, would bypass grafting be necessary. And I think that's a key message. The primary therapy of this disease process should probably not be coronary bypass grafting. And if one does bypass grafting for this, one has to give some consideration to ligating the native vessel, which is a maneuver that we all undertake with some real trepidation. As a coronary surgeon, my business is to increase flow to the heart, not to limit it. So I'm loath to do that myself, except in that very, very rare occasion where an unroofing might go wrong and one has obvious ischemia trying to come off bypass. Clearly, as a bailout, a bypass graft is necessary.
Yeah, well, it's fantastic insight, and it was a great CABG Academy. And having you here, I can't avoid but ask you the questions about these recent ACC guidelines. So we've got these guidelines. They to a lot of people, they seem not to be putting the indications for triple vessel disease where they ought to be. What would you say your insights are and a way forward with this?
Well, I would agree with that statement. I don't think that the guidelines presently give the indications and classification for surgery that is appropriate for triple vessel disease. I think that coronary bypass surgery still remains, and I think will remain, the best therapy for multivessel coronary disease in adult human beings, period. That said, I think that the ACC went astray, if you will, in misinterpreting the results of the ischemia trial. And in the ischemia trial, patients were not randomized to PCI versus coronary bypass grafting. They were randomized to having invasive coronary angiography or not in the setting of other indication of multivessel coronary disease. And when analyses were subsequently done, those patients who had revascularization were lumped together. And roughly 3/4 of those who were revascularized had PCI, and roughly a quarter had coronary bypass. And to lump those two techniques together and call them revascularization is the fundamental fatal flaw of all of these analyses, because they are not the same thing. They don't work the same way. They have never worked the same way. They never will work the same way, and they should never be lumped together. It's convenient to do so, but it is intellectually and academically dead wrong. And it leads to conclusions later that are also dead wrong and are, I think, dangerous for patients.
And I think the STS have taken great leadership here. Sort of surgical members on that withdrew their membership of that guideline. And but where do you see us being able to go with this controversy? Do you think this is a guideline we can revisit, create our own guidelines?
This is the first time in some years where we have not had consensus between cardiology societies and cardiac surgical societies on revascularization guidelines. We had happier days some years ago when we had joint guidelines committees, and I think that's where we need to go again. I think that the selection of those members for the committee will be important, but I think that we also have to have, real intellectual rigor in contemplating the basic differences between PCI and CABG. They cannot ever be lumped together as revascularization. And the reasons are important for surgeons to understand. PCI treats a flow-limiting proximal stenosis. It reopens that proximal stenosis. Most human beings who have multivessel coronary disease have flow-limiting proximal stenosis, but they also have adjacent lesions which are not flow-limiting. They don't have, many of them have hardly any areas of the coronary arteries that are normal. It's just that the very proximal lesion may be more dramatically stenotic on an angiogram. So that's where the stents go. And we know from Courage and other trials within the PCI world that stenting only the flow-limiting lesions is the right treatment if you're using PCI. But coronary bypass works by a completely different mechanism. We bypass the proximal half or 2/3 or even 3/4 of a vessel, including the proximal stenosis that is tight. So later, as that proximal stenosis progresses and worsens and perhaps closes, or more likely, one of the more numerous non-flow limiting lesions progresses and has a plaque rupture and causes occlusion proximally, the coronary bypass graft, which is then present, provides protection. So this is the concept of surgical collateralization, which has been known for many years and which was so beautifully articulated by Torsten Dunst and others in a JACC paper 2 or 3 years ago. This concept of surgical collateralization as protection against future myocardial infarction is the fundamental difference between PCI and CABG. And that is why CABG versus medical therapy has repeatedly demonstrated a survival benefit in stable coronary disease, whereas PCI has actually never demonstrated a survival benefit over medicine in stable patients with coronary disease. Because PCI treats the flow-limiting proximal lesion, does not treat non-flow-limiting stenoses, which are numerically much more common. And it is therefore in those non-flow-limiting lesions that many future events will occur. PCI cannot protect against those events, and CABG does. Therein lies the advantage, in particular for patients who have more diffuse disease. So the higher the complexity of coronary disease, the greater the benefit of CABG over PCI. Well, what's happening in the human population? Are we getting more or less complex coronary disease? We're getting more complex coronary disease. Why? Because obesity and diabetes has become the physiologic norm of Western society. When I began my practice of coronary surgery, I hate to say a quarter of a century ago, but it's true, 10 or 12% of my patients had diabetes. Now it's 65% of my patients have diabetes. Literally in one practicing lifetime. Now the norm is more diffuse, more advanced, more triple vessel and left main disease in a configuration that clearly will benefit more from coronary bypass than stenting. However, if stents are used, we end up with more and more and more stents. And now we get back to the conversation that we began about stentectomy and full metal jacket.
Yeah. Absolutely. Well, I mean, I think that is such a clear message to all our readers and viewers here. Absolutely barn door. We must understand the fundamental differences. I'd love to say we need to do more trials. The trials exist. That's the crazy thing, isn't it?
So we need to take the trials at face value. They're real. We need to talk about FAME3. There will be an update at this excellent meeting here at ACTS 2023. I'm looking forward to that presentation as well. We need to understand the benefit of what we do, but we also need to be improving our game too, right? One of the great talks at this session was by Mario Gardino, talking about the radial artery. And while we can all debate radial artery versus right internal thoracic artery, which is better, I think that's a moot point. It's clear that the radial artery beats a vein graft. And to me, it's been clear for at least 2 decades that what we as a profession need to do is not just one arterial graft. Let's just move the whole group of us, all of us surgeons, from doing a mammary and 3 veins to doing a mammary, a radial, and 2 veins. If we just did that, we would improve outcomes for coronary patients globally to an extent that the PCI CABG debate would be even more demonstrably advantageous to coronary bypass surgery. To talk about radial artery versus Rita, it's a moot point. I use both of those arteries literally in every case. I think it matters how you use them. There's no reason to believe that a Rita, which is anatomically and biologically identical to the Lita, is any less better than a vein than the Lita is. I think it matters how you deploy it. If you are taking a free Rita off the aorta, that's a tricky proximal anastomosis because the IT is smaller than a vein or a radial artery. I think sewing a Rita to the aorta is much harder to get perfect than sewing a vein or a radial to the aorta, simply due to the size mismatch. So I never do that. I use the Rita in situ. Now, if you use the Rita in situ and you drag it to some target which is just a little too far away, and the Rita is taut, the patency will suffer. And so the data that Dr. Gaudino showed, they are the data. He's showing the truth. These are the numbers. And I think we need to think very carefully about how we use the Rita. I use the Rita as an in situ graft in every case, but it is never directly to the coronary artery. It is always elongated with a piece of radial artery, so that my Rita is never taut. It is always slack. And I think that's a fundamental rule in arterial bypass grafting. If it even occurs to you that that graft might be a little too short, it's too short. Because at some point that patient's gonna cough or sneeze or do something that's gonna prove to you that's too short. So make them slack. And that to me means in our normal operation, our everyday 6 or 8 times a week operations, double mammary inflow and radial artery outflow with slack grafts to 3, 4, or 5 arterial targets. And I think if we look at, I am confident, just because of the biology of ITA grafts versus radial artery grafts, that the Rita, being biologically identical to the Lita, will have the same benefits if we use it right. But if we don't, it won't. And I think that's what we've been doing, and that's why the data are what Dr. Gaudino showed.
And I think Mario Gaudino is thinking about some new trials in this area.
He always is.
Do you have any thoughts on?
I think it's brilliant. I'm looking forward to enrolling patients.
Yeah, great, and hopefully we'll see more then. Well, it's been absolutely fascinating talking to you. I think everybody should come spend the day with you and really see the absolute best CABG that's possible. And from all of us at CTSNet and everyone in the whole community, thanks for leading so well in this area, and best of luck with your next marathon. Because I hear you smashed the New York Marathon, and maybe there'll be another one coming soon. Hey?
And no medals involved. Just finishing upright is my triumph.
Right. Well, thank you so much, John. It was an absolute pleasure talking to you.
Thank you, Joel.